Okay, ladies and gentlemen, we are ready to call the meeting of the Rutherford County Benefits and Insurance Committee to order. And you have a copy of the minutes before you of the last meeting on May the 23rd. We need a motion on approving these minutes. And Ms. Hickerson, have a second from? Okay, several, Mr. Hester and others. Okay, did anyone have any corrections or additions? If not, then all of you in favor of that, please say aye. Aye. Any opposed? Okay, that carried. Okay, Mrs. Stinson, you can now tell us about the financial condition.
Good afternoon. We'll begin with Fund 264 if you refer to those documents in your packet. For the end of fiscal year ending in June 2013, our per employee per month for our self-funded claims experience was $641.79 compared to prior year of $726.96. The year-to-date average on the self-funded claims was $803.65 per month compared to prior year of $791.32. When we combine our on-site medical experience for the fiscal year, we ended at $680.48 per employee per month compared to prior year of $762.15, for an average of the year of $839.07 compared to prior year of $824.93. There is an additional document in your packet if you will refer to that. This document is a revenue versus expense comparison sheet that I'm providing to you so you can see where we are at the end of the fiscal year on a calendar year basis. On the other report, it's a fiscal year. This is a calendar year basis, and you can see that currently we are trending above. But if you'll look at 2012, you will see that as we book experience for July, August, and the remainder of the year, you start to see a change in what the numbers look like. So I will be providing this to you on a monthly basis so that you begin to review what our costs are tracking, because before we know it, we'll start talking about 2015 premiums. So this is just information only for you at this point. We can move on to Fund 266 now if you refer to that report. Ending in the month of June, our year-to-date was $767,385, up 43% from prior year at $535,792.
Okay, do we have any questions regarding the financial statements? And Mrs. Stinson, on the second fund there that's up 43%, is there any explanation for that, or should we be concerned?
Mr. Good will provide you with the OSHA report ending in the month of June, and he'll let you know what our experiences look like, which is actually what drives those claims.
Anyone else have any questions about the financial? Overall, it looks good.
Yes, sir. That would be our
assessment of
agreement.
That. Okay, that being said, then we're ready to move forward with the workers' comp and OJI statistical report. Mr. Good will do that for us, please.
Good afternoon. You have your report in front of you, and what I'd like to do today is present for the month of June, but I'd also like to report for you for the first 6 months of the calendar year. You'll notice in the month of June we had a total of 15 injuries requiring medical attention. You see the breakout there as to what the nature of those injuries were. Brings the year-to-date total to 88. Of those 88, 61 of them were OSHA recordable. 62 of those injuries had restricted days attached to them. 11 were lost time days or claims or injuries, and then 8 were all others. On the next page, you can see where this year is compared to the 2 previous years. Just want to mention there, as you look to that, it's a little difficult to really tell where you are. In 2011, the first bar that you see there, the total year-to-date in the first 6 months for 2011 was 131 injuries. In 2012, that had come down to 94. And the year that you're looking at there in the triangles, 2013, we have had a total of 88 in the first 6 months. Also, I'd like to bring your attention to the month of May in the triangle, if you would. That is a total of 6. That is the lowest that the county has had ever, 6 injuries in a given month. And the last time, one other time, we've equaled that, and that was in June of 2008. I mentioned in June, also, school's out. In May, school was still in. So you need to take that into consideration when you look at that figure for May of this previous year. Next page, you'll notice that of the injuries that were reported in June, the total incurred dollars was $21,420. And next page shows that of those injuries, 8 of them were in the county general. And you'll see the breakdown there as to the nature of those injuries. And the next page will show where those were in the county general, between the Sheriff Department, Emergency Management, and the Judicial Building. The Board of Education had the remaining injuries totaling 7, and the total dollars incurred there was $8,150. Present to you the total for the year for the first 6 months. You'll notice I mentioned we had 88 injuries, and the total dollars incurred so far in the first 6 months of this year, $170,114. Of those 88 injuries, 34 of them was in the county. Again, you can see the breakdown there. Notice that in the county, struck or injured by is our number 1 cause with a total of 12, while slip, trips, and falls is the 3rd highest in the county that we had in the first 6 months of this year with a total of 5. And I want to bring that up here in the next couple slides or pages. You'll notice on the next page, the 34, you'll see the breakdown there of where they are in the county. And you'll notice that, of course, where would you expect to find most of the injuries in the county area? And that is in the law enforcement, where they deal with individuals and they're exposed to great hazards there in law enforcement. And that's where the majority of the injuries are for the county in the first 6 months. The next page, the Board of Education had a total of 54 injuries. They had $81,000 as a total incurred. And you'll notice here that slip, trips, and falls are still a big issue for us in the school system. And that's understandable. If you've ever been into a school system, been in the classroom, teachers are trying to teach, walk around the classroom, observe students, watch what's going on. And, of course, students have a tendency to stick things out in the middle of the floor. Teachers will trip and have those issues. In addition to that, our schools keep our school system, county school custodians, keep the schools highly polished on the floors, keep them in good repair and things like that. Water and things fall on the floor also because of the students lend itself to a high volume of slip, trips, and falls. So that's where our majority of our injuries are in the school system. On the last page, as you flip over, just to kind of present to you where the dollars go. In 2011, year to date, if we were to look at the first 6 months of 2011, for the first 6 months, those dollars incurred were $356,000. If you were to look at the 2012 year, it was $343,000 incurred. And this year, if you notice, of course, it's down. That's $170,000. Now, I would like to caution you when you look at that $170,000, please remember that that's only for the first 6 months. They've only had 6 months to mature, while the other 2 years have had a year to 2 years to mature. And those dollars will still continue to go up, of course, until those open cases have been closed. That's all I have at this time. If there's any other questions.
Anyone have any questions? Okay, Mr. Good,
Yes, sir.
if you look at this page that Ms. Stinson reported to us, in June, on the other self-insurance claims, there's $474,000 credit. Is that when we sort of have an appraisal of all of these outstanding claims? Do we make adjustments, or?
With the actuary, we'll have an actuary study, and based on that, we'll
Okay, so when we do the actuarial studies, we make this adjustment, so that's sort of, that made that year really come way down after we made those adjustments and those actual assignments that had already been made to the potential claims cost. So that's a little bit explains why the 43% is there. We hadn't yet put the actuarial, well, yeah, we had done, but this year's actuarial study produced a much more favorable result, it appears. Every 2 years. Okay, so we didn't have that in 2012. So that, okay. I got you. All right, then.
Thank you very much.
Thank you very much. Let's see, the wellness update. Ms. Stinson will be doing that on behalf of Ms. Perrion today.
You have a couple of documents in front of you. You have what you traditionally see, which is the Smart Steps Wellness Program. We will walk through that document first. And it does have May and June information included in it. If you look for prevention, there was a mobile mammography done in May on the dates of 6 and 7, and we had 33 in attendance, and this was held at the Blackman and Stewart's Creek MedPoint clinics. Wellness on Wheels, screening and awareness, we had the county clerk's office and register of deeds. We had 23 in attendance. May wellness coaching had 13 actives. June wellness produced 9 actives, and these are primarily in our Blackman clinic, but we do have some for Stewart's Creek in the month of June. Upcoming events are free screenings at the Woman's Show at Tri-Star Stonecrest on August the 1st from 5 to 8 p.m. There's an exercise class that will be held at Stones River Church on various dates during the month of August. We do have our healthy cooking class, which typically has good attendance, which is Skillet Lasagna this month, and it is held at the Rutherford County Health Department. There are other things noted on this report, which you can see, which extended through the month of September, and Ms. Perrin will cover those in the next month's meeting. We participated in the National Business Journal's 2013 Healthiest Employers. Finalists include Rutherford County, and the awards presentation occurs in the month of August, so we'll learn at that point how we ranked against others in our category. As part of that, there was a survey that was sent out to employees, and we had 285 employees complete the survey. As you can see from the graphs, if you refer to the second page of your document, it's actually the back of the first page, insurance premium reductions is the #1 incentives that employees are looking for in terms of their wellness. Other information included in this survey is regarding communication, and the email newsletter was the highest that was desired in that particular category. There's other information in here as well, which I will let you review, but these are relevant to other pieces of information that we have up for discussion. If you'll look on the back of the second page, you'll see that incentives, including gift cards, reductions in premium, was one of the others that were mentioned as desirables by employees. And one of the resounding themes from the 180 comments that we received as part of this survey is employees are looking for opportunities to exercise, and they're looking for gym memberships, particularly free. And there was a lot of requests for teachers to be able to utilize the gyms in the school, the weight rooms, etc. So the report with comments was forwarded to Mr. Odom for his review and consideration, because that's really outside of something that we can do as part of our wellness program. However, we did glean from this that our current method is the email newsletter, so we will look for ways to better incentivize employees to review that on a monthly basis as it's sent out, as well as we do have discounts at most gyms. Sometimes it's a nominal amount, but there is some level of participation by most gyms in the area. And there is going to be an outreach program by the wellness coordinator to see if she can get a gym to sponsor a monthly free membership. So once a month we would be able to give out a free membership. Now I know that's only one out of the 5,200 people, but we do utilize this information to see how we can improve our program. So we will be moving forward with trying to address the exercise issue that most people responded back with.
Okay, any other comments regarding this wellness information? All right, so agenda item number 5, open enrollment.
On this particular item, I am looking for direction from the committee typically during open enrollment, if someone is currently enrolled in a plan for 2013 and they do not complete the open enrollment process, we will, if they're currently in the deductible plan, they would remain in the deductible plan. If they are in the HRA or the copay plan, they would default to the deductible plan. With the insurance premium increases that we're having this year, I'd like to hear your feedback on if you feel that is the appropriate process to follow. There's two schools of thought. We could continue that process, which could be substantial for some employees to incur the cost. And I'll give you an example. In 2012, for the 2013 plan year, we had 7 individuals from the copay plan default into the deductible plan. So they saw a premium increase. We had 13 in the HRA go from the HRA plan, which was free, to the deductible plan and start paying premiums. We had 253 people who were in the deductible plan who did not complete open enrollment who stuck in the plan that they were in. So if you look at those numbers, if we change from anything, this gives you a better idea as to what we're doing. Now, there's 2 different schools of thought. One is we could allow people to just stay where they are this year. So if you're in the copay, you stay in the copay. If you're in the HRA, you stay in the HRA. The thought being there that the HRA is the second highest category of individuals who does not complete the open enrollment process. They're already going to incur a fee this year if they even stay in the HRA unless they're employee only. The other thought is that the HRA plan is our lowest cost plan on a per member basis for the county. When we look at our claims experience, it has the lowest claims cost associated with it. So I'd like to hear your feedback as to whether or not you think we should continue with our ongoing practice of defaulting people to the deductible plan, whether or not you feel like we should move the default program to the HRA plan because it has the lowest premiums associated with it and it has the lowest claims cost on a per member basis, or do you think that we should allow people to just stay in the plan that they are enrolled in 2013 should they not participate in open enrollment?
Let me ask her one question before saying 253 people were in the deductible plan that did not fill out, and so they went into the deductible. One of your options was going to take them to an HRA plan.
Yes, sir,
so
that's
we would
correct.
affect a much larger percentage
Right.
of the population if we went that approach.
That's correct.
Okay, than we did previously.
Yes, sir.
Because we let them stay in the deductible because that was what we defaulted them into. Ms. Stevenson?
I just wanted to make sure I heard you right. The HRA plan is the most cost-effective for the county or for the employee?
It is the most cost-effective on a claim basis for the plan, which would be both the county and the employee.
Okay. But as far as the premium goes, the county's portion, which of the plans is the cheapest?
The HRA.
HRA is for that too.
Okay, Mr. Sandvig?
One of the discussions we've had in the past here is that, especially for some of our lower income employees, the HRA plan, if they have a lot of prescriptions in particular, could put quite a financial burden on them. I tend to favor letting people stay where they are, and if they don't go in, and if they are in the deductible plan and don't make that change and are surprised by the premium increase, they had the option. But since we went with a shorter re-enrollment period this year because of the health care reform changes that then got postponed, I like the idea of letting people stay where they are if they don't re-enroll. And part of that is because of on the HRA side, for family, that will be a $2,000. We'll have the first $1,500, and then they'll have $2,000. And I'm kind of hesitate to do that as a default at this point. And I'm not sure for 2015, when the health care reform is in place, that the HRA will necessarily be the default we'll want at that point either.
You are correct that a lot of times what prevents people from being a active candidate for the HRA is their prescription utilization and whether or not they can fund those costs initially until they reach the maximum. So he is correct in what he has said about that.
Mr. Jordan?
I'm just going to agree with Mr. Sandvig. I think we'll just leave them where they are. A lot of people, and I don't know why, but they just pitch all their correspondence in the trash can, and they don't take the time, and they'll be right where they were. And if they have an increased premium cost, that's their own fault. They should have paid more attention. But we're not going to put somebody in a plan they can't afford the prescriptions or whatever. You know, there won't be any surprises except for the premium, and that's their own fault. So I would strongly, personally think they ought to be left where they are.
Other comments, or does someone wish to make a motion? Ms. Harvey?
I just want to say I agree with what Mr. Sandvik said, but I had a question. On this open enrollment, it's just going to be talking about the medical plan. We're not going to be talking about anything of choices for life insurance. Nothing new is going to come up other than selecting the medical plan. Is that correct?
Well, no, not exactly, because we have a new life vendor in January. So there will be information for all the lines of business that they have to choose from, all of their benefits.
Right, so I can see if you keep them in the same plan, which is what I think we need to do, you're going to have people that says, well, I'm going to stay where I'm at, so I'm not even going to go on the computer and do anything because I'm going to be where I'm at. And I was wondering how that's going to affect those other choices because they won't be selecting anything.
Well, that is correct. And we certainly won't promote not going in because if, you know, there's always an opportunity that you have forgotten what your benefits are. And we always encourage everyone to go in and look at it. I will say one more thing. There's always the option to default it to the copay plan if you're looking for a different option as well. But individuals need to go in and log in. My concern with leaving everyone, I'm not opposed to it, but my concern about it is once we get to the healthcare provision where they have to either accept or decline coverage, then we're going to have to make some decisions at that point of what will we put those individuals in, and that would be an employee only. So behavior sticks so quickly that I just don't want in the future, you know, we'll have to do a very good job of communicating that this may be just this year and come up with a more long-term strategy in the future, depending on what premiums look like.
I'll make a motion that we stay default to the plan we are for just this year.
Okay, we have that motion. Do we have a second? Mr. Sandvig seconds that motion. Further discussion? Okay, there being no further discussion, all of you in favor of that then, please say aye. Aye. Any opposed? All right, thank you very much. Okay, next we're going to talk about the Wellness Initiative, and we're going to allow Mr. Jay Brown with Cowan Benefits to lead that discussion.
As Mr. Brown's coming up, I'll go over the documents that you have in front of you and make a couple of points for your consideration. You have before you three particular documents. This is the third or fourth time that we've brought this to you, and this goes back to prior conversations about having individuals do a biometric test in order to avoid an additional wellness fee. Now, originally we had looked at making it part of the premium process, but because we've already set premiums, what we are recommending is that if we move forward this, that there would actually be a payroll deduction line. So it would be a $25 payroll deduction line, which Mr. Brown will go over in his part of this discussion, that would show just like any other deduction from their check. So it would show that it's a wellness fee and it would say $25 and it wouldn't be an inflated or deflated premium. The premium would be what has already been passed. Okay, so that's one thing I want to clarify for this discussion. After the last time that we met, the wellness coordinator in my office reached out to 95 contacts representing all of the counties in the state of Tennessee. And the benefit survey that we did included wellness information, and you have that before you. Of the 95 counties that we contacted, 32 counties responded. There were 27 of those 32 who tied wellness directly to the premium. And 20 of those counties participated on the state plan. I think that's important information for you to know, particularly that last number, the 20 that participate on the state plan. If you'll look at the Partners for Tennessee document, which is the second of this packet, you know, a lot of times in discussion, it's said to me, how do we compare to the state? And if you'll look at the top part of this particular document, the state in 2011 did a Know Your Numbers campaign. So how do we compare on wellness? We're a couple years behind. What we're proposing of you today and what we've proposed in the past is the Know Your Numbers campaign. The state is controlling their claims through increased wellness initiatives year over year. Their first year was Know Your Numbers. 2012, participants who were identified had to partake in the wellness initiative. In 2013, I've provided you with a long list of requirements that they have from a wellness perspective in order to receive a reduced premium. The last document is the one that Mr. Brown will cover, and this is really the meat of the communication for employees. You all had asked to see what would we give to employees, and I will state that there is one typo error. If you will go to the first paragraph under to complete the biometric screening, the January to September timeframe should be reflected for 2013, not 14. So, Mr. Brown, if you'd like to go over this, you can explain what the process will entail, and we can go from there.
Yeah, this would be a document that we'd include in the enrollment packets and also talk about during the meetings. But the thought would be, especially based on the feedback last time when we met, is because we've already passed the contributions, as we talked about, really have that separate line item, because we still have to incent the employees in some form or fashion to participate in the program. And so with this particular program, the way we looked at it is if we have open enrollment meetings in October and they receive their packets in early October, potentially opening their packet and reviewing that, this would be in there. And it says that there's to avoid a $25 per month wellness fee, you must participate in the biometric screenings. And essentially, the offering now is it would run from October 1st. If you look down in the kind of to complete the biometric screening, simply follow these steps between October 1st through February 17th. So essentially the beginning of open enrollment all the way through to February 17th. During this time, you would either go to one of the MedPoint facilities, a Take Care clinic, or go to your personal physician if you want to do that. So we've expanded that a little bit more to do this biometric screening, which really the main thing we want them to get is a blood panel, a lipid panel biometric test. And the reason why we focused in on that is if you see a CPT code there, that we can pull from Cigna's reporting to see if somebody's had that one CPT covered. So instead of them having to submit something in to the principals or to risk management, we can run a report to see if they've done that. And then we extended it out to say, even if you've had your biometric screening, a lot of you guys, when we asked last time, you raised your hand, you've already done it this year, or, with the program, normally you can go get a full body examination once a year. And so that may not fall into these parameters that we're setting here. So our main goal is to get employees to know their numbers, not just to go get the biometric because we said so. So if you've already done that, we want to go back and give credit from January 1st of 13, essentially all the way through to February 17th. And the reason we kind of picked that date is that we need to have time to run the report from Cigna, analyze it, and then get that information into the payroll system to affect the March 1 pay cycle. So essentially January and February would be the contributions as they've already been approved. In March, if you do not participate in this program or have not done your screening, at that point you would have that $25 monthly charge for not participating in the wellness program. And obviously it would be adjusted between the Board of Ed and the county, what that per paycheck cost would be, the 10 versus 12 pay cycles.
One thing, too, that's important to note is that we did a query in the Cigna system to see how many had completed the biometric, the lipid panel that's shown here, through June. And it was 675 of our 5,200 employees.
So one question, last time we asked how many have done it, a lot of you guys had already done it. So we went back to say, all right, of the 5,200 employees, how many have already done this? I mean, is it a moot point? And for half of the year, 675 people have done it. So that's a pretty good indication that this may be something to try to encourage them to do.
Was it just that they had only done it if you've been sent
But those two are pretty prominent in physicians' offices, so I would think that it's a very, very small margin of people that would have gone through a different lab.
Done
vendor.
different things too. We actually ran the report we were actually specifically looking at this one CPT code. There were about 8 other categories we could look at, but of just doing this, which obviously if you go get an annual exam, you get a blood draw, you want to know your cholesterol and all the things there. That's one of the main things you would do initially. That was kind of the 675 number.
Mr. Jordan?
I've got 2 questions. One, I take it for granted the $25 would roll to the insurance fund instead of staying in each department's budget or whatever. My concern is for the finance department. How big a headache is this going to be for them to keep up with this? You know,
Really, it comes from our end. We build it in the risk management department as a deduction, just like we all do all of our others.
when they hit it, go straight to them. I mean, they're going to have to, as long as, I think people ought to be accountable for their own numbers now, and I don't have a problem with this, but I just don't want to beat them over the head in the finance department where they've got, a changing number every 2 weeks when they're sending out
But
checks.
it
that
wouldn't
have
be a
this.
changing number. I mean, once you either meet the deadline or you don't, and then it's for the remainder of the year.
I'm trying to remember our past conversation. We've
It's
done this several
$25
times.
per month.
Yeah, I was under the impression you could get it done a month later and then drop out. But once you've missed the deadline, it's next year. You're basically losing $300. Yeah, I'm starting the conversation coming back to me now because I had hoped would have a way that somebody could, well, if they didn't get it, they get it next month and they get back in more or less. But
Well,
that's
we
a total
extended-
nightmare as far as her office is.
Yeah, so we extended it. Initially, we were looking at about a 4-month period, and now we've extended it for the whole year 2013 plus January of 2014 and half of February.
That goes back to my previous comment, though. People are going to get all these flyers and emails or whatever, and they're going to ignore them all until they get their check, and it's $25 short, and then they're going to go ballistic, but they're going to have to live with that for a year until the next
And at some
opportunity.
point, even on the conversation in that last kind of vote, I mean, what we're really trying to do is make people more accountable for their decisions. I mean, we really just don't want them to go bit of biometric screening. The goal is to see the numbers and then actually go do something about their numbers. So, I mean, that was the kind of the thought on the HRA too, is that we really have tried over the past 3 years to educate during open enrollment meetings about the HRA plan and move more people in that direction. And we had a really good push initially, and then it's kind of slowed down a little bit, largely because I think a lot of people don't come to the meetings. They don't read their packets. So the thought was, well, let's default them into the HRA. We want employees, because this is a big year with contributions, I think more people will read the packet than they have before, because they've heard all the information over the last couple months. So we really want them to get engaged in that decision. And so one of the thoughts were, if you move them into the HRA, maybe they'll take a little bit more effort to make sure, is this the right plan for me? If we keep them in the same plan and say, you don't have to do anything, and keep your plan, most likely they won't read the information. So at some point, either they're picking up plans or wellness, or just trying to take baby steps to get employees more engaged in their healthcare decisions so that we don't have another 20% rate increase. And this is this is probably the smallest baby step you can take in wellness to at least get it moving in that direction.
I think the expectation is that when they go to their physician, if they go to their private physician, they'll probably run additional tests as part of a full physical. Additionally, it feeds into the disease management programs at Cigna, which gives them better resources and management of their disease processes. So there is a trickle effect to this beyond just making people be accountable and trying to contain premiums.
It's RB.
I like the idea that we're now going to be able to do this in midpoint if this passes, but of those 600 people that have already done it versus the others, how will you know, what if you can't remember if my blood work included the cholesterol and those kind of things? Is there a way that they can call Cigna to say, have I already done this? Or is there going to be some information sent to them saying, you've already met the criteria, you don't have to worry about it? I mean, how are we going to communicate who needs to do what?
There again, there is some accountability to employees, so they would have to call their either private practice or MedPoint to find out if they've already completed that.
Confirm when they went that CPT code is something their doctor wrote down and submitted into Cigna.
Ms. Nolan?
On the second paragraph, where it's after a biometric screening, starting with you all the way to per month, make that red. And this last paragraph, make that red.
And this is employees only. I do want to stress that as well. We're not talking about spouses or dependents. We're only talking about our employees at this point having to do this.
For me, my eye goes to red. And I just want to, there's 2 points in here where you have said $25 a month.
And this is, I didn't say this initially, but we actually do work with a whole marketing firm to do the benefit communications for you guys. So this is something that I came up with, this format that we've used with some other clients. Most likely we will transform this to look more like the benefit guide and the colors and things like that. So the verbiage, if you approve, will be the same, but the look may be a little different.
Other questions, Ms. Stevenson?
When we were having our meetings before, refresh my memory, weren't our spouses the one who was causing our claims data to be the highest?
Not necessarily to be the highest, but their cost runs about equal with employees.
Okay, so if somebody wants the benefit of our plan, why aren't we making them hold their numbers accountable too? I don't understand.
Well, we certainly could do that, but you have to start somewhere. And there's been a lot of discussion about this. I mean, even this discussion, just talking about employees, has been a difficult discussion to get any momentum going. So we've tried to minimize the process to the basic level that we can to still make it meaningful, to try to get this level of momentum, wellness momentum going in the county. So starting with the employee is phase one, and it is a multi-year. I know that Commissioner Durden had concerns about it is a multiple year approach. Next year, it would make sense that it would be employee plus spouse, and it would continue to expand, much like you see the state of Tennessee. What I am concerned about, though, is if, there are a lot of counties already doing this, and Rutherford County is doing nothing. And if we stay behind in terms of what we're doing, we can only carve the plan so much, we can only build designs so much, we can only do so many audits and other things to try to save money. At some point, it is a partnership with our employees to offer a health plan that is affordable and provides the services that they need.
Okay, then Ms. Hickerson, you can finish.
I guess my concern is for most of us in this room, we were at all of the commission meetings, all the budget meetings, and all those other meetings, and it was voiced by several of our commissioners who thought that the county's expense was too high. So if I look at it from me as an employee perspective with a spouse on the plan, if I'm wanting to ensure that we can maintain the benefits, I would think that the employees would want to do their part and what they could to ensure that we kept the costs low to maintain the benefit we have. That's my only concern, that if we know that that's an expense, that's really a small step to ask an employee and their spouse who's on the plan to get a physical. That's a small request.
So, Mr. Brown, I'll ask you a couple of questions in case there's others of the same thought process. In the situations where you do employee plus spouse, do you keep the rate the same of $25? And then second to that, what happens if the employee does it but their spouse does not? Do they pay the $25? Do they get any type of credit?
Typically, you do start with the employee in the first year. Because I'm trying to think, well, let's get through all the next 2 committee meetings, that we're trying to get the communications out in time. So that would be a challenge, I think. But essentially, it would be $25. And typically, it does increase, or we would change it for spouse. Most of our wellness plans for the first couple years largely relate to employee. Typically what is in the first year you do this, in the second year you may have to add doing the health risk assessment, and typically it's the employee that does those things. I totally agree that if you're really trying to eat healthier or exercise, it's better when you have your partner next to you doing that. It gives you that motivation. But administratively, it doubles the work too, which makes that a little tougher, because typically we would say maybe if you want to do that, it would be $25 for employee and maybe another 25 for your spouse, because it's requiring 2. And so now we're seeing who did it, who didn't. Well, only the employee did, but not the spouse, so do we give them 25? So, I mean, I think you would look at them as 2 individual people and charge 2 different prices. And so then it doubles the administrative, which, like we said, we want to make this administratively, because at the end of the day, I think that's the challenge, and getting the employees to do something to get them passed through, is make it as easy as possible this year. But the goal is this is just a baby step. Next year, I'll have 3 more suggestions for you guys to consider, and the next year the same.
Ms. Hickerson.
Okay, I think this is a great idea, because we as a society we have to be responsible for ourselves. And it was mentioned in the May meeting and in our minutes that we have consequences for our actions with our other insurances, car, home, life. If you do this, you have to pay more or whatever. So the health insurance needs to be the same way. We have to be accountable for it. And I think we do need to just do employees only now, because, I mean, it's baby steps and a little at a time. I want to ask, mainly to make sure I'm thinking right, the state plan that this mentions, and that is page 2 of what the state plan is doing, does this affect what the teachers can go to when they say they can go to the state plan? I guess what I'm trying to say is, if the teachers ever decided to go to the state plan, I'm just trying, would they have to go by these guidelines of already having to have, they would have already been hit by the know your numbers and then participate? So really, ultimately, by doing this time, we're only starting to get where the state plan is, which we kind of have to make sure for teachers in negotiations that we are comparable to what the state offers? Or is this state plan here totally different than what the teachers can get on board? Because I'm all for this, and we may need more discussion, but I'm to the point I can make a motion, we go with this, because it is what it is, and we have to be responsible.
Mr. Sandvig, I think, wants to answer that question.
On the state teacher plan, there are 2 different tiers. Basically, the slightly lower premium tier has slightly better pharmacy and some other benefits. And if you are in the, whatever they call it, if you are in that, pardon?
The standard or the partnership?
Yeah, if you're in the standard, you have a higher copay for your prescriptions. So there are different, you're basically in Plan A or Plan B, and you only stay in the preferred plan, and that's not the right name for it, if you get your annual whatever, blood draw, whatever those things are. If you don't, then you default into the more expensive plan the next year.
So there actually is one option, if the teachers went to the state plan, not both of their options force them to do the know your number.
No, both options do not force it, but you pay a slightly higher premium and have some slightly reduced benefits. Yeah, you pay for not doing it, but it's built into the rates.
And that's true of any state employee. They have 2 sets of rates. They have these, and then they have higher rates if you don't participate. Yeah.
We have other clients that say you have higher copays and deductibles if you don't do it. We've kind of chose to do it through payroll deduction.
And this is easy baby steps right now.
This is
Ms. Harvey?
Okay, I think at our last discussion that we had, one of the main questions that I was concerned about was what were we gonna do with these numbers, and how are we gonna use these numbers in the future, maybe not this year or next year, but, are we gonna say people that are obese gonna have to pay more, or smokers gonna have to pay more, those kind of things. So I think that's gonna be a question that I'm gonna hear from a lot of teachers, is gonna be, what are you gonna
Question. I mean, and at this phase of this, the way we're doing it this time, we will not know the numbers. I would prefer to have a model where we would get access to know the numbers to kind of know how to focus a wellness program. But essentially, anytime you go to the doctor to get your exam, that information gets fed to Cigna today. And as the county, we don't have access to that data. We don't look at that data. One option I was suggesting is have it flow through the on-site clinics or have a vendor come in where it would flow through them and we would have access to that data. But under this option, employees can go to their own doctor, they can go to the MedPoint clinic, they can go to the Take Care clinics. All that's going to Cigna, and we will not get an aggregate report of that information, so we wouldn't see that information. Down the road, that may be an option to go that direction, but as to make people feel comfortable about the way it is right now, the county would not get an aggregate report of that data.
But I think it is fair to say, though, that a lot of the things that you brought up are standard wellness, smoker, non-smoker, all of that standard wellness. So to answer your question, are we gathering data so we can figure out how to better manage subsections of employees in the future? Well, some of that is just standard wellness program management, like the smoker versus non-smoker. You would have to do a blood draw to pull nicotine levels in those type of situations. It wouldn't be from this data that we're going to get from this test that we would decide to that. There's just some tried and true practices in wellness that we would probably review and recommend for implementation just because they're done regularly at other places and they're proven to be effective.
I have clients that are, 5 years. I have clients today that do exactly what you said. They look at the biometric information, and we have an outside vendor that audits that information and sets your contributions based on your biometric information. I have clients that do that, but you're nowhere near that today, where you're, so.
Okay, other questions? Mr. Sandvig?
So we would not go back and pull. We're going to assume that everyone's going to do it for January and February. So the first deduction really would occur, so it's $250 is my reason to bring that up. Yeah. So the credit, in terms of the credit, I'm not sure that I understand that if they do it later in the year, can we credit it?
Yeah. And that's the way I would prefer it, and that's kind of why we brought this up earlier in other meetings before the contributions had already been voted on. But now we're at a position where all that's already been decided, and so now how do we financially incent? And it's with a more, I call a stick approach. I would rather it be a carrot approach where you do this and you get a credit, but I don't think we're in a position to go back and open up the county's budget and now say, we need more money, essentially, because we talked about the employee costs and the county costs. If we give the employees a credit, that means the county takes a debit. So we can't do that now at this point. But I agree, most of my clients would prefer to show a credit than a debit.
When we talked about this very first, it was at the work session that we had with premiums. And at that point, there was such a concern, as I recall, of what the premiums were going to need to be that we didn't get any momentum. So then we brought it up 2 other times, and we're locked into the rates now, so we just simply can't do that. Now, if we do the spouse the following year and we increase, then we certainly would want to make that part of it.
Or just next year in general, if we get this baby step here and the next time we are able to go the next step, whether that be add the spouse, we can tie that into the contribution discussion. So when we're talking about contributions, we can say, here's the recommended increase, and then budget giving them a $25 credit and work to see what those numbers are.
The dollars are the dollars, but really the bigger discussion on the floor here is what is our culture? And are we ever going to get to the point where we want to make our employees accountable? And I really believe, even though we're not speaking in those terms, that's just as large of a consideration as it is for the financial aspect of it. The money will motivate. If people are truly concerned about the $250, they have plenty of time to get it done, plenty of ways to get it done. It's just culturally, are we willing to take that stand, and are we willing to do that?
Okay, we've had this discussion. Questions? Or do we have anyone that wishes to make a motion? Oh, Mr. Hester.
Just to be sure, we had a motion on the table at the last meeting. It was deferred. What exactly does that mean?
Well, let's see. Good question. Let me read my minutes.
I think the motion was to defer it to this meeting for discussion.
Okay,
Decision wasn't made.
so there was not a motion.
I think so.
Well, the motion was made just to defer the issue, the discussion, until the next meeting. So we didn't actually defer but that motion,
Commissioner Jorgensen said.
did, well, you made the motion. I need to read this. I don't see that we have reflected that a second was made. Did you see that? Okay, the motion was seconded by Ms. Hickerson. Okay. Okay, so I think after reflecting and reading this carefully, that motion, the motion itself that Mr. Hester made was deferred until the next meeting. So that motion is still standing and is ready for a vote. Correct.
That time frame has now changed, so does something need to be done to the motion to adjust for that?
Yeah.
I'm talking about the time frame for the screening.
Yeah, they've extended the time frame for the screening, and they put in place, if you've had one January through September, that counts.
If somebody can make an amendment to change the numbers to reflect today's, and I'll
make the amendment to reflect the change of the time frame from
Okay.
January
All of 2013.
through September 30th of 2013.
So basically, anyone that has this done between January 1st, 2013 and February the 17th, 2014, that would be the time frame that amends our previous discussion.
Yes, sir. Make that motion.
And a second on that motion from Mr. Jordan. Okay. Now, are you ready for a discussion or a vote on the amendment? Any discussion on that amendment? Mr. Hester?
Another question, are we voting on the amendment only?
Yep, first. All right. All in favor of that, please say aye. Aye. Are there any opposed? All right, so the amendment is passed, so we've got that time frame in place. Now let's go back and vote on the original motion. Mr. Sandvik, discussion?
May I make an amendment?
Yes, sir.
Or propose an amendment? I would like to amend the dates to make this effective for 2015. I am concerned about the appearance of a $25 a month rate increase for people who do not follow through. I would like more time, but that is my amendment.
Have a second. Ms. Harvey, discussion.
I think that's a bad idea. We've got to start on these baby steps. I know I'm one of the commissioners, but there were a lot of talk on the commission floor, but we've got to do something. We've got to start making some changes. That pushes this back a year. That puts us to their second baby step, to back 2 years, and I think the commission's expecting some action, this year, and that would basically make this null and void. So I appreciate Mr. Sandvik's motion, but I would respectfully ask you to vote no.
Mr. McAdoo?
I concur with Commissioner Jordan. We had this on the floor, and the commission is contemplating that we want something done. We don't want to be putting it off. So baby steps, we're making baby steps, and we got it in the budget, and now all of a sudden you want to extend it another year? We never will reach our goal if we keep this up.
All right, you've had that discussion. Ms. Hickerson?
Just a little comment on what our commissioners are saying. If the employees take this $25, if we're stuck with paying the $25, this is our effort to try to better our insurance. You know, whether it's to help our premiums or not, the employees should see this as our chance to help the situation, because the county does pay out quite a bit on our matching, because I have the benefit of seeing both sides of what comes out of my payroll check and then what I, as the highway department, have to pay on the matching for each of the men. So I am totally against putting it off, just like Commissioner Jordan and Commissioner McAdoo. So I just want to go on record as saying this is what the employees should appreciate, that at the most, I know $250 in a given year is a lot, but have one wreck and see what your auto insurance happens, or have a claim against your house and see what your homeowner's insurance does. So we have to be responsible for our health insurance and our health care. If not, we're going to end up running this in the ground that we don't have the benefits that we're used to or that we feel we're required to have. It could totally be taken away from it because nothing is set in stone. It has to be offered.
Okay, Ms. Stevenson.
I think we're missing the point. They only have to pay the $250 if they don't go get one blood draw. It's a simple thing. It takes 2 minutes. So.
All right. There's no other discussion unless we have before us an amendment to move this, the timing on this forward away 1 year to 2015. So if you vote yes on this, you're voting to postpone this for another year. All right, so all of you in favor of that amendment, just raise your hand. 2. All of you that are, it's 3, excuse me, Ms. Grace, I didn't see 3. All of you that are opposed to this, raise your hand. 1, 2, 3, 4, 5, 6. The amendment failed. Now, we're ready to vote on the motion unless there's another amendment. All of you that are in favor of the original motion, please say aye. Aye. Are there any opposed? Let the record reflect that 2 people were opposed to this, and that means 7 of us voted yes, and so the motion is carried. Okay. Now, is there anything else, Mr. Brown or Ms. Stinson, on this issue?
No, sir.
Okay. Thank you very much. Now, let's see. MedPoint clinic locations. Are you addressing this, Ms. Stinson?
Yes, sir, I am. If you refer, there's a document inside of your packet that has the MedPoint logo in the lower right-hand corner. Take Care does a really good job working with me in terms of the budget and providing me with financial information that allows me to do a thorough review of what our clinics are performing at from a financial perspective. And they will actually go through a business review following this discussion on this particular item with you. During discussions with Mary Asherbranner, who is the Take Care representative that I work with most closely, we were looking at clinic utilization. And from that discussion, it rolled over into requests for what our costs associated with specific clinics are. What revealed is that 2 of our locations, which is Rock Springs Middle and the Health Department, are not being heavily utilized for the period of September 2012 through March of 2013. The utilization percentage at Rock Springs Middle is 34% capacity versus Health Department, which is at 46% capacity. What that means is that we have nurse practitioners and support staff that are waiting for people to come. And as they wait, it's costing the county money. The recommendation that I would make to the committee is to consider closing those 2 locations. We have expanded our service offerings at Stewart's Creek Clinic, and we have extended our service offerings into the retail market. And through that, employees would only be required to drive either, if they typically go to the Rock Springs Clinic, to get to the next closest clinic would be 2.5 miles. If they typically go over here to the health department, the next closest clinic is 3 miles. So asking employees to do that would save us about $100,000 a year in operating expenses. So my recommendation to you is to review the information in front of you and take under consideration closing effective August 1, the Rock Springs Clinic and the Health Department Clinic. Those are also our two smallest locations, and to be quite honest, they're not very well. The Health Clinic, just so that you know, we basically utilize their rooms for care, okay? So that's a great setup. We basically utilize a space inside of the Student Health Center at Rock Springs for our employee clinic. It's not as if we are looking at closing a site that would be comparable to Blackman or Stewart's Creek or Walter Hill or one of those locations. These are single-source treatment rooms, not multi-source sites. So the recommendation that I'm making is that so we can better contain our expenses inside of our plan, we're not putting too much on employees, we're talking about a couple of miles here, that we close these two locations effective August the 1st.
Ms. Harvey?
Mm-hmm.
If we close these two clinics, would there be a possibility of opening another clinic, maybe not this year, but in the near future, say at Rockvale, to catch some of the overflow of the Blackman Clinic?
Actually, the solution that caught the overflow of the Blackman Clinic is the Take Care site on Cason Lane, which is just a couple of miles. So that's already providing relief. We had about 64 employees that used the retail site in the last month. So we are seeing utilization there. Can we open a clinic? I don't know the answer to that. I don't know if space is allowed in any of our school locations out there. I don't think we have any county buildings that I can think of off the top of my head that would allow for that. And the cost to do that is about $250,000. But we did expand our Stewart's Creek Clinic throughout the last year to have 40 hours of walk-in treatment as well. We are rarely, I think that every once in a while I'll see within a month we may have had to turn one person away if we have an influx of people. But it's very, very minimal. So we are able to provide the care that's needed. Dr. Dooley is spending a lot of her time down there at the Stewart's Creek Clinic now. And from Blackman to Stewart's Creek, you're only talking about a couple of miles as well. So again, it's what is our culture, and what should we provide, what are we providing, and what do we need to do from there. And I really think that we have a lot of coverage right now.
Mr. Jordan?
I just had a question about employees. If we close these two sites, are we moving those employees somewhere else, or are we sending these people home?
Well, these employees can move to another midpoint. I mean, typically you will find that most people use one site more than the other. We looked at who's using these sites, and if I recall, I looked for a nod in the back of the room. I think the retirees were using the health department the most. Is that correct, Ms. Asher-Branner? We had a lot of retiree utilization of the health department. I looked at Rock Springs to try to determine, is it primarily the school teachers in that school using that site?
But I was talking about the employees that work in the clinic, the nurse practitioners.
Well,
are they contract labor anyway? But,
they are, and they'll adjust their schedules and utilize them in other clinics.
But it's just their schedule, and we're not going to actually be turning those people.
No, that's right.
Mr. Sandvig?
And just, do you know right off the top of your head some of our other utilization figures, Melissa? I mean,
I don't have it with me, but I can.
Much higher.
Oh, they're much higher. I mean, as far as I know, the Blackman Clinic is typically always fully at capacity. That I know. We do have capacity at Stewart's Creek. I know that, particularly on the walk-in clinic. We have more capacity available. And then Walter Hill, as I understand, stays pretty full, almost at capacity as well, if not at capacity. So, but I can certainly bring you that information if that's something you're interested in.
Ms. Harvey?
If we decide that this is what we want to do, what time frame are we
They would be closed effective August 1. We have currently suspended the calendar, just awaiting a decision on this, primarily for the reason that I didn't want the teachers at Rock Springs to come back into the school and then close the clinic after school has opened. Since the meeting was moved to July, we've kind of had to take some measures to awaiting your decision.
Ms. Hickerson?
If we go back to our very first page of our financials that you always present to us, I mean, it is kind of silly to have these two open for the usage being such a low percentage. Do you foresee this is going to help bring down the on-site medical cost because we're not paying for dead time or downtime, I should say?
You would see some adjustment in the cost, I would expect. Of course, if those individuals go somewhere else, then the cost associated with that treatment follows them. So I don't know exactly how you would see it on a monthly basis, but you would expect to see a little bit of shift because we have the downtime right now. And the $100,000 reflects the full time when they're treating and not treating.
Could we not, have you looked to see with the hour span, could we not adjust the hours to a smaller, like 12 to 4 or 10 to 2 or something like that and have a cost savings, or is it sporadic?
There are extremely limited hours at these two locations already.
Okay, you've heard this discussion. Mr. Sandvig?
I'd like to move to approve closing these two clinics October 1st.
Second, Ms. Hickerson.
I said August 1st. I said August.
August 1st?
The recommendation was for August the 1st. Oh, okay.
I thought you said something else. Okay, we have a motion and a second. Ms. Harvey, did you want to say something? All right, is there any other discussion? Everyone in favor of this, then please say aye. Aye. Are there any opposed? Okay, we've done that. Now, Walgreens review, the first quarter of 2013. I think we're going to have Trent Riley, the Chief Operating Officer of Take Care, and Mary Asherbrander, the Senior Director of Site Operations of Take Care. They're going to talk to us about this, I believe. So come on up and give us your review.
Also have with us today Joanne McDonald, which leads the Central Region, which Rutherford County falls into, the Central Region for Take Care Walgreens, and Mary reports to her. I'd just like to thank the Mayor, Ms. Stinson, and entire Insurance Committee for giving us the opportunity to present our first quarter results here today. Just from a highlight perspective, we continue to provide Rutherford County employees with excellent care through early identification of disease and aggressive management, guided by our evidence-based protocols and strong clinical oversight. We've also been able to strategically partner with Rutherford County to expand our services availability. So you heard Ms. Stinson talk about our retail footprint. So we added 16 sites from a retail perspective that has very similar services to our MedPoint. With that, we've already also been able to expand hours of operation to give Rutherford County employees more access to care after hours. We also have strong medical leadership at the on-site facility. Dr. Tanzi Dooley is our medical lead, and she's board certified in internal medicine. And we've also been able to add Dr. Lanes Tippins, who is board certified in occupational medicine and emergency medicine. We also continue to collaborate and partner with Rutherford County on employee outreach and programs such as Wellness on Wheels, really guiding them to programs to improve their health. With that, I'll hand it off to Mary, and she'll go over our statistical highlights.
I appreciate you letting me present to you this afternoon. It seems a little bit funny to be standing in front of you instead of behind you. But there again, generally we do find that we support you dramatically and dramatically, hopefully in good ways. So on the highlights that you have in your presentation packet, the quarterly highlights for Q1, and this is Q1 of 2013, so this is the first quarter of this year. There are 3,343 total encounters in Q1, which is an increase of 6% over Q1 of 2012. And You have 2,097 unique members of the eligible population have utilized the MedPoint Health Centers for a penetration rate of 18.1%. The next bullet point to me is very important because the penetration rate since the inception with Take Care Health and the MedPoint clinics, which was September 2011, is 41%. Meaning we've touched points with approximately 41% of the population, okay, of Rutherford County. On the next one is our direct cost avoidance decreased 13% as compared to Q1 of 2012. However, the quarter's actuals were 29% higher than the projected feasibility model. And if you remember from the model that we were given, we anticipated the cost, okay, of what services we would be providing, and we are above that. So that means that we are doing better than what we had anticipated that we would be doing at this time. On it, our total expenses for Q1 decreased by 5%. Our savings were 21% lower in Q1 of 2013 than in Q1 of 2012. However, the actuals were 11% higher than projected by the feasibility model, and this is due to, I believe, increased medication adherence. And this is extremely valuable to you in Rutherford County now and in the future, as compliance with medication is critical to the success of the health and wellness of your employees. So, for example, if you have one patient who is compliant on their cholesterol medication on it, in a study that was done by the American Heart Association, you have the potential of saving $117,000, which is the cost of a triple bypass. That is huge when you look at it from that perspective, and that's just one. Other studies have shown, especially one that did a review of studies in the American Journal of Medicine, showed that patient adherence ranged from 10.1% to 17.8% in coronary artery disease, but this broad scope was actually anywhere from $294 per patient to $868. So even though we had a decreased savings on it, the actuals were higher than projected based on the medication adherence. If you will turn to the next slide, what we're looking at there is actually a highlight dashboard of the summary that we provide Ms. Stinson on a quarterly basis. And this shows in the top left-hand side you have the total encounters. And you see the beige-colored line for 2012. And the spike in the September and October timeframe have increased in flu, but also flu vaccines during that time. And then you see the blue line for 2013. So you can see our total encounters are tracking right at or slightly above where they were in 2012. The penetration rate we had mentioned earlier, and you can see again, it's showing that it is total penetration is the blue, and then provider penetration specifically. Penetration is what we're looking at, unique individuals. When you see an individual on it, it doesn't matter how many times they've been into the clinic, on it, they're only counted as one visit or one person, okay? And then the bottom left is our top 5 diagnoses. And we do primary care light, acute care, with some basic primary care services in our clinics. But as you see, we have upper respiratory tract, acute respiratory tract infections, which are definitely there. Preventative services, working from the wellness side on it. But you also see the hypertensive diseases are coming into play in this quarter. And so we are definitely working more with hypertensive cholesterol, elevated cholesterols and that. And we're looking to continue to expand there. Then the net savings summary is on the bottom right, and that shows you where we were in Q1 as compared to Q2, the model on which was our feasibility side, and then the variance in where we are. So with our net savings this quarter of $221,236 on it, that is slightly less, as we said, than in Q1 2012, but as compared to the model, okay, we are $57,277 better than what our feasibility model showed. Does anyone have any questions?
Okay, Ms. Stinson and Mr. Brown, you guys have reviewed this. Do you have any comments about what they've just told us? I understand, the net savings is less, 2013 versus 12. It is greater than the model, and that largely is reflected by the total cost avoidance is less. And how do you compute total cost avoidance?
Total cost avoidance, what we do is we look at the direct cost avoidance, which is we use the CPT codes that are standardized across the industry, and says that these services that we are providing cost X amount of dollars in the community. And then we look at also penetration rate as far as utilization, preventative health services and things are there also compared and put into that total. And then we subtract out the direct cost or the direct expenses.
Okay, yeah, the direct expenses, I can see that. So you have to take the codes that determine what services they've needed and used and reflect that you project a cost.
Okay. The CPT codes are standardized industry codes, okay, and the value that is assigned to that is specific to Rutherford County, and we have based that on what Rutherford County has been using with their insurance company.
So when we first established these reports, Mayor, I sat down with Mary and another individual from Take Care, and we walked through a lot of the data elements to make sure they were specific to us. As an example, what is our average per hour cost of an employee? What do we typically see from a physician's PCP visit in private practice inside of our Cigna book of business, and other data elements like that? So what they do is specifically what she said, which is to take those services, project what they would have cost outside of MedPoint, and that's where you get your cost avoidance.
Okay. All right, any other questions or discussion on this? And Ms. McDonald, not to leave you out, do you want to say anything about this?
Just that I'm happy to be here, and I look forward to working with all of you. Thank you very much.
All right, thank
Thank
you. Thank you. Okay, is there any other business to come before this committee today? Anything else, Ms. Stinson? Anyone on the committee have anything they'd like to discuss? All right, that being the case then, thank you for your participation, and we are adjourned.